And then just share my screen. So as I said last night, I think the majority of you do know Tony. And I also think, I don't think there's anyone here tonight that wasn't on last night's session as well. If I look at the names, so I do think that everyone currently saw last night's presentation as well. So we're not going to labor too long with introductions because as you know, I'm the course convener overall for the grad cert, and I'm also the chief examiner for the grad cert. So in terms of any assessments, I play a major role there. And then Tony, you want to maybe say a sentence or two before we move on?
I think it would just be probably repeating what I said last night, but
I think you're breaking up on my side. I'm not sure if it's just on my side.
okay.
That's better.
Yeah. Okay. It might be just this headset. It's pretty old.
Okay.
Yeah. But look, I won't bore you with more than what I said last night. I think I met you all last night and getting to know each of you a little bit better as the nights go by, I think.
All right. Okay. Thanks, Tony. And then just acknowledgements of country. Monash University recognizes that its Australian campuses are located on the unceded lands of the people of the Kulin Nations and pays its respects to their elders, past and present. And this is just the copyright about the material. And for all four of the units, including this one, the two of us, myself and Tony, we take responsibility for the teaching materials, and I've given you our contact email. And this is just the introduction to tonight in case somebody missed where the Zoom link was. Now, I'm just going to stop and go to the Moodle site. Let me just make sure it's ready. Yep. Okay, so we've gone through last night with the dashboard. So the dashboard basically gives you the content, more or less an idea of what happens. And also any forums that we post information will come up here as well on the dashboard. So in case you've missed something, this is where you might have a look at some of the posts that's been posted. And then in terms of the unit information, so there are the links to the timetable, and I would really encourage you to especially look at when there's assessments and also when exams are taking place. As I said last night, the exam is available over 12 hours. Make sure that you book time off before exams, because quite often, especially with postgrad students, you are working and you come back home 5, 6 o'clock, and then you quickly want to do the exam. So make sure that you give yourself enough time to be able to do the exams. I've gone through the reading list last night. So if you click on that, that will take you to the ebooks, and I'm not going to do that again because we've done it last night. But I'll just open up on the assessment summary. And similar as for RAD4502, can you still see my screen with the assessment summary, Tony? Have I lost you?
Yeah, the assessment summary didn't come up. So I think you probably shared the page rather than shared the screen, you know.
Okay, so it's,
yeah.
let's just go back to share the screen. Okay, you're able to see it now?
Yeah.
Okay, so there's 3 assessments. So this assessment for 5108 is different than for 4502. You're going to have one ISAP case. You're only going to have one exam, and then there's a clinical portfolio, which is different, which is not something that we introduced for 4502. Now, again, in terms of competency, The ISAP case doesn't have a hurdle competency, but the exam and the clinical portfolio now has a competency hurdle. The exam is much longer because it's going to be over all the material that's been presented. So it's a 100-minute exam with a weighting of 40%. And then the portfolio, which I will discuss just now, has a weighting of 30%. The case study, the ISAP case study, also has a weighting of 30%. So that's the three main assessments. And then let me just go back to share the screen. Okay, so that's then the unit information. And in terms of the learning outcome, you should be able to see week 1 content. Now, I didn't focus much on these 3 tabs. So own time is what you will be doing most of the time, because all of the materials are delivered and you can work through those material at your own time. So you will find most of the material under own time. Real time is when we have face-to-face, like tonight, where we have got a Zoom face-to-face session. So that's where you will find real time. And so now and again, we will wrap up is at the end of the week if there's maybe something that you expect you to do towards the end of the week. And I'll go over the clinical portfolio in a moment. So under real time, you will see tonight's session and then also the PowerPoint as well. So mainly what you will find will be under own time. And then assessments, let me just see what comes up. It's always a mystery with the assessment tab. So it shows the exam, which will take place on the 3rd of June and 8 p.m. is basically the deadline for you to submit the exam. So that's the due time that when the exam will close. And I see the clinical portfolio doesn't come up yet. Okay, so let's just stop share that one. Tony, anything you wanted to add with the Moodle site?
No, I don't think so, Imelda. I think the important thing is that you guys have actually taken some time to have a bit of a tour yourself and sort of see what goes on, and that you've got hold of those timetables and that you sort of use those as a guide to what you might do from week to week.
And especially if you have got more than one unit, it would be good to have a planner for this, for the semester, so that you know exactly when you need to submit work. Especially, I know quite a few of you are enrolled in all 4 units, to make sure that you plan accordingly. Okay, so I'm just going to continue with the PowerPoint presentation. So I fixed up all the links that didn't work last night. We just had to re-upload them again, Tony. So
right.
Yeah, so everything is working now. So we've gone through the overall grad cert. And then the next one would be the learning outcomes for this unit. So this unit focuses on the upper limbs as well as the cervical spine. So all of the material that we present will be on that, and that is also what you will be assessed on. This is a link that will take you directly to the handbook. So if I just click on the handbook, and probably will have to stop share again. Okay, so the handbook gives you an overview also of all the learning outcomes for this specific unit. It also gives you the assessments, and then where the competency hurdles are. So for those 2, exam and clinical portfolio, you need to pass both of those to be able to pass the unit. And then also with your workload requirements, the expectation is at least 6 hours per week in the learning materials and 6 hours of self-directed study as well. Now, there's no specific fieldwork requirement. However, you need to have access to medical imaging because of the clinical portfolio. You need to base that on clinical cases, X-ray cases specific to this unit. Okay, let me get on with the resources. So again, as mentioned last night, all of the material are released on a week-by-week basis. The same manual that's available for 4502 is also, some of it will be linked to this unit. And then, as I mentioned, our material is mostly produced as Moodle books, including PowerPoint presentations. And then you've got access to the reading list and library resources as well. I've spoken about the image manipulation software, which you will use in the ISAP cases. And for this unit specifically, you will be using it in formative as well as in the final exam. And there is a demonstration with a video recording about the software, but I'm quite sure most of you are now probably familiar with that. For the exam, there will be specific login details to access the software. Now, Tony, I've managed to get all these links working. So I might just open up the radiographer's sign up form, because we couldn't do that last night. And stop share and then just share again. So this is the online form. So Tony, do you maybe just want to talk through that again?
Yeah, as I said last night, this is a very good resource and something that, I mean, it's additional to, it's not directly linked to what we're doing in this RAD cert, but nevertheless, if you've got some spare time and you'd actually like to have a look at some additional cases, some further cases that'll hone your skills, I think this is really useful for you to make use of, because you get the feedback, and you get the feedback from reporting radiographers, consultant radiologists, a whole bunch of different people who are actually make use of this. Not all the cases have feedback, but I think probably every week there's at least 10, maybe 20 new cases that'll actually pop up, and they're from all over the world, and they're often well worth a look. Some of them will test you, some of them test me, because they're complex, I guess, a little bit more challenging, as some radiographs can be. But the good thing is that eventually, if not immediately, someone's actually going to go on there and they're going to give you a comment, and they'll actually tell you whether what's going on. And if you've already put in a comment, you can indicate your degree of confidence. Probably better off to aim too low than too high, and then they'll tell you whether or not you're right or wrong, and give you gentle feedback. Everybody's really nice on that website, so there's no rudeness. So I think it's a good resource. But I guess if you get the time, and as I said last night, there is a spot there for this course that you can actually put cases up linked to this course directly. So we could actually all go in and have a look at that case and give you feedback about it. Yeah.
Yeah,
Way
thanks.
to test your knowledge. Yeah.
Yeah, it also includes some of the more low prevalence type cases, some more unusual cases as well. And it's always useful to learn about that because you're never sure where you are going to end up. And it might be one of the cases that might be more prevalent in the country where you might work one day. So quite useful to link up with that. And the sample case here is one of those rare cases, I think, with, is it Bertolli or something of the spine? But you can click on these links and then also go through the sample case as well and see how they address the sample case. But you can only get full access to the sample case if you've signed up on the form. Yeah.
Yeah.
And then Ian Cowan, you've talked about. Do you want me to
I
click on
did
that?
talk about Ian and Ian Cohen's X-rays, and look again. I've referred to it a few times in the lectures, but you know, certainly again, it's a really useful site, and Ian's put together some really nice PowerPoint info. He and I worked together in Fiji with radiographers from Pacific Islands, and you'll see that you know, if you go and have a look at Ian Cowan X-rays, you'll see that some of the material that Ian's used, I have recycled. Some of it was my material originally, but I've also Ian's given us permission to actually use that material. So, but I recommend that site, and it's a site that's actually designed specifically for radiographers. And I know I'm not talking to all you know, you're not all radiographers, but I think you're all in that position where, you know, you may interpret radiographs in the front line without necessarily having someone that you can call upon for an expert opinion. And really, that's what Ian designed his website for, is to address that need, particularly for radiographers who are working in developing countries. But I think it applies quite well to our course. And as I mentioned last night, I learned a lot working with Ian, and I think you guys can as well.
Okay, thanks, Tony. So just a summary again of the assessments. So the first task is the ISAP case, and then for this one, for this unit, it will be a cervical spine. And the deadline, so that will be the first assessment that you're going to do. That deadline is going to be on the 28th of March for the CAP report. And then the ISAP, the CR report is on the 12th of April. It seems long, but it's because Easter is in between. So during that holiday week, there's no submission of any work. So the ISAP case then doesn't have a
good catch up time though.
Yeah, yeah.
Falling behind, make use
Yeah.
of it. Yep.
Definitely. So the ISAP case doesn't have a competency hurdle attached. Doesn't mean you mustn't do it because every assessment contributes towards your final mark. And then the online exam will be done during the formal exam period, which is on the 3rd of June. And it covers all the material of those weeks. But I'll be giving 2 formative assessments, so one halfway through and one at the end, so that you review the material as you go along. And also it will give you an idea of the types of questions that will be asked in the final exam. And then the clinical portfolio, that deadline is in the final week of the exam period. So for this unit, it will be on the Monday. And we're going to go through the clinical portfolio material in a minute.
Can I just interrupt again
Yep.
for a second, Melda? I'm just looking at the timetable here, and next week you've actually got an introduction to the cervical spine ISAP case. And
Yeah.
you've also got the adult cervical spine trauma clinical decision rules. And both of those things, the clinical decision rules as well as the introduction, relate to the ISAP case. And you can get in and have a look at those. And once you've actually got that access to the ISAP case, after you've had the introduction to the ISAP case, you'll be able to go in and read the clinical scenario and have a look at the materials that are associated with the ISAP case. And you can start thinking about it, or start even making notes, make use of the cervical spine rule and any other resources that you might be able to lay your hands on. So even though you won't have actually had lecture material on cervical spine trauma, I think next week you can still go in and start doing a little bit of work around that ISAP case, so that then when the 28th of March comes along, which is not all that long away, of course, only about a month away, you'll have actually already made some steps in the right direction, at the end of week 2. And then week 3, there's actually a lecture on cervical spine trauma, as well as some anatomy and pathology quizzes that you've got to do. So, yeah, I just thought I'd mention that. Thanks.
Yeah. Tony, I thought maybe just for the students' sake, in week 4, we've actually going to include some additional material that's not going to be assessed. And quite often with cervical trauma, it can also be an association with facial bone trauma. So we are going to include a presentation about head and facial bone trauma in a Moodle book for you to go through, but that will not be assessed. So that's why with the additional resource, this is non-assessed material. It's just for your own benefit that we will be adding that material. We haven't done it before, but we're going to do it this time around. And I've talked about academic integrity. So the compulsory module, if you haven't received an email from the university for this unit to complete the compulsory module, you would probably have received it for RAD4502 if you have enrolled for the first time. So you don't have to do it for each of the units. You only have to do that compulsory module once. So if you've done it last year, for example, you will not receive an email to invite you to complete the compulsory module. And I've talked about generative AI. So on the Moodle site under support, there is the Learn HQ dropdown. If you click on that, you will be able to access more material to understand how AI can be used in student work, and then also how to cite and reference when you use those kind of resources. So for the ISAP case, for example, you could use generative AI, but you need to acknowledge that you have used that material. And then the special consideration, this link works now, but I'm not going to click on it because we talked about it last night. So the main thing is you can get a short extension of 2 days, but you need to submit your request. So if the assessment was today, you need to submit it before the day is over, before 5 to 12, for a short extension to be considered and to be approved. And as I said, you don't need any supporting documentation, so you will be able to get 2 calendar days extension if you are experiencing difficult circumstances. But for anything else, you need to it's still the same link. However, if you want anything longer, you have then to provide supporting documentation. So the first case is the ISAP case, which will be a cervical spine. And as I said, 2 parts to the ISAP case. You've got a clinical action plan of 1,500 words. Remember, there's a 10% leeway. And then you need to submit a comparative report, which is 500 words. So the overall weighting for the ISAP case is 30%. That's why important, although it doesn't have a competency hurdle, you still need to complete this task because 30% is a lot to lose out on. So make sure that you stay on task. And then as postgrad students, you're only allowed one submission and it automatically goes into the Turnitin matching software to see if there's any evidence of plagiarism. And if, as I mentioned last night, the cap for the faculty is 15% or less in terms of similarity index with the Turnitin report. But if it's more than 15%, sometimes there might be, you might have repeated the actual scenario. It picks all of that up. And we normally go in and check if there's any evidence of plagiarism. And then once you've submitted your CAP report, and when the deadline has been reached, so if the deadline is 28th of March, 25 to 12 that evening, the experts' reports will only become available just after 12, basically the 29th of March. So in the early morning of the 29th of March. And then with the experts' report, you then need to compare and contrast your CAP report and then write a comparative report. And that you will also see in the Moodle book. The Moodle book will also show you the marking rubric so that you can see how we are marking both of those reports against. So the Moodle book will be available under week 2 because that's when we are going to introduce the ISAP case. So next week you will have access to the Moodle book. Then the online exam. So it's going to be a big exam for you. It's only one exam year. The weighting is 40% for that exam. And so the resources will be all the material under the weeks 3, 4, 5, 7, 8, 9, 10, and 11. So it's a couple of weeks work, but there will be 2 formative tests. So halfway around week 8, I'm going to give 1 formative test. And then week 12 is the last teaching week. We will have formative test 2. And you can use those formative tests to prepare yourself for this final exam, as it will show you the types of questions we're going to ask. And then also when we use the image manipulation software. And what I normally do with the formative test, I give video recorded feedback so that you can self-mark yourself as you review the formative test feedback. But if you've got any questions, please contact either myself or Tony. So the exams will be run from the Moodle site. You will have access to the image manipulation software as well. And as I said, on that day, on the 3rd of June, the exam will open up at 8 o'clock in the morning and it will close at 8 p.m. So you need to ensure that you allow yourself enough time so that you can complete the exam before 8 p.m. because it will automatically close down. And then to ensure that there's academic integrity when you do the exam, there will be a statement that you need to accept before the time. For the exam, AI is not permitted. And then the Moodle exam, as well as the image manipulation software, password protected, so I need to provide you with your passwords to access the exam. So I will normally email and say, send out an email to say, let me know what your suggested start time would be so that I can provide you with the login exam details. And then the clinical portfolio is in the last week on the 17th of June. So I'll go over the clinical portfolio in a minute. So you need to collect a minimum of 25 clinical cases specific to this unit. So you need to include the cervical spine as well as upper limb, so your shoulder, your elbow, your wrist, your hand, your humerus and forearm. And then each of those cases, approximately 80 words each. Some of the cases you would use less because there's very little maybe that you want to write. And also remember, not all of your cases must be pathology, because you're going to work out your specificity and your sensitivity. So you need to have normals as well. Each case is marked out of 4, so there will be a total of 100 marks. If you want to, if you've got an interesting case, you could actually include a reference to that case to show that you've done some further research, but that does not mean you have to do it. It just shows that you've gone that extra mile to ensure that you have the correct knowledge to be able to write up that specific case. And then there's also a self-auditing PIE, stands for preliminary image evaluation. And from that, you will be calculating sensitivity, specificity, and accuracy, and then reflect on your personal abilities to write a comment on each of those cases. Now, what's important is when you submit your clinical portfolio is to identify each case chronologically. So go case 1, case 2, case 3, case 4. And then also, as I go through, I will talk about assigning true negative, true positive, false negative, and false positive. And then you compare your comments to that of the radiologist. And that is how you're going to work out the statistics for the self-auditing record. So the main thing with the self-auditing PIE, I think the majority of you will agree that when you look at a radiologist's report, they will include lots more than what the clinical question is asking. So say, for example, if a patient comes in with trauma of the neck, they might see some chronic arthritic changes, which they will also comment about. However, for you, for this clinical portfolio, if the question is trauma, so you want to see if there's any fracture or any soft tissue signs, that is what you need to focus on. So if the radiologist has mentioned, for example, arthritic changes, you don't need to mark yourself against that, because that's not answering the clinical question. The only time when it's really crucial to, if say, for example, the patient has been sent, say, for a humerus, where a fracture, and you actually see that there is pre-existing condition, there could be a aneurysmal bone cyst or something like that. So it's then useful to include that as well. And then make sure that you have a range of the body area, so that you have cases that will include the shoulder, the humerus, the elbow, the forearm, the wrist, and the hand, and of course the cervical spine. Now, sometimes when you complete, you assign true positive, true negative. So say, for example, if the patient has got 2 pathologies, there's 2 fractures, but you've only identified one, then you will assign only half a mark as true positive, because you've identified half of it, and the other half will be a false negative because you've missed out on that. But each of the cases, when you assign, your fractions must equal 1. And then from that, you will be calculating sensitivity, specificity, and accuracy. And then a brief 2 or 3 sentence about your reflection on your personal abilities, image interpretation abilities. And it could be something like, for example, you say, I really struggle to identify pediatric elbow pathology. I've missed out quite a lot on that. So something in that vein. Also your strength. So if you find out you're really good with interpreting the shoulder, that's something that you can say as well. And when you submit your clinical portfolio, there again will be an academic integrity statement that you need to accept. And I've just given an example of how to write up one of these cases. So for this case, the request is for a forearm. The clinical indications is a fush injury. You need to include at least one de-identified image. Ensure that you have got no identifying information on the image that you include. So no patient name or doctor's name or anything else that's there. So make sure it's de-identified. And then an example here of a PIE is there's a comminuted fracture to the distal radius with dorsal displacement. There's an associated ulnar styloid process fracture. And then when you compare it to the radiologist's report, so the radiologist included, there's an acute comminuted intra-articular fracture of the distal radius. So the one thing that you've not mentioned then, according to this report, is you haven't mentioned is intra-articular, which is quite significant. And that is then where you will assign fractions as well. So you've identified the distal radius, that is comminuted, there's dorsal displacement, and there's an associated styloid process fracture. So for that one, your true positive will be about 3/4 that you've identified, but you've missed out on the fact that it's also intra-articular. So use this as an example when you write up your clinical cases. Okay, so I'm just going to stop share here and then just quickly ask if there's any questions before I go to the Moodle site where I've uploaded the portfolio.
So before you do it, Imelda,
Yep.
before they ask questions, I might just make a couple of comments. I could envisage that some people might have difficulty compiling cases for the medical imaging clinical portfolio, particularly to try to find cases that actually cross over all of those various regions. There's some ways that you can do that. Like you could actually use archived images. So cases that have been, they're not current, they're not being done, in real time. They've been done before, but in order to actually meet the criteria for the clinical portfolio, then, maybe you've got to go back and actually have a look at some historical cases. I know that the people from the John Hunter won't have that problem because there's lots of cases go through there. But with you guys and with all of you, that you don't necessarily need to, you don't have to have done the case.
Yep, that's
It
important.
could be someone else who has actually done the case. But you've actually observed it and you thought, okay, that's a good case to actually include in my clinical portfolio. I'm going to actually keep track of that one. So that's important that you can do that. I think the other thing about it is to stay in touch with us. Give us a yell if you actually are having any trouble pulling cases together. And we'll give you some advice about how you might be able to go about that. I think the challenge for some of you who are not working in the medical imaging department is going to be making contact with someone who is, so that you can actually then tap into them as far as collecting cases is concerned. But if you're having that problem, then please give us a yell and let us know, and we'll see how we can help. And that might mean, helping you connect with someone who's out there in the field and able to provide you with access to cases that are relevant to this portfolio. Is that okay, Imelda?
Yes, yes, that's absolutely
I haven't stuck my foot in it or anything there yet.
No, as long as you find the person. You know Queensland and New South Wales much better than me. So you might be able to identify, if someone like Mel or is it, I can't remember his wrist. If you have issues with getting access to cases, I think the main thing is to maintain integrity. So if you get those cases, don't look at the report first and then write up. Look at the images and write your own opinions first before you compare that to the radiologist, because this is a learning process to ensure that you get the most out of the learning process. So that is the only thing that I would like to add there.
Yeah. One thing that I might just say is that sometimes the radiologist report's not right, and that sort of creates a little bit of a complication for you. Whether or not you actually go along with the radiology report, or you accept the fact that that they might be wrong, but you're actually going to give them the benefit of the doubt on this occasion and sort of say that they're right.
I can, Tony, sorry, before you move off from that point, it's a good point that you're making, because there was one of the radiographers in this course who actually worked, I think, the night, and there was, of course, no radiologist to report. And when she did the X-ray and applied all the lines, you could see it was a pediatric elbow, that there was a dislocation of the radial head. Now, that's something that can be missed if you don't draw those imaginary lines, which you will learn about through the delivery of the unit. And she went around to the emergency department. It was a fairly junior doctor, which I looked at it and said, "Oh, that's normal." And she said, "No, it's not." And she actually drew the lines. And when she drew those imaginary lines, she saw there was a dislocation. So the patient was then treated for the dislocated radial head. The next morning, the radiologist reported it as normal. So the radiographer looked out for that report and then went to the radiologist and just said, very discreetly, can you just have another look at this case? Because I think there's a dislocated radial head. And then when he looked and really drew those lines, he also saw it was dislocated. And in fact, in his report, he acknowledged the radiographer, because he would have sent out an incorrect report. So in some of those cases, it's useful, to actually speak to the radiologist. And maybe you're right. Maybe the radiologist might be wrong as well. But communication is really big in terms of your learning process as well.
Yeah. And it doesn't mean the radiologist is bad. It's just a reality of life in medical imaging that there are going to be mistakes. And this is the point, or one of the points, that I was trying to make in that introduction lecture this week
Yeah.
about clinical error, is that it occurs, and it occurs probably to a much greater extent than we would like it to occur. But the idea of actually having more people looking at it, other than just a single radiologist who's maybe camped in the back of the department somewhere, is to actually have more people actually making a comment, having their opinion thrown into the mix. And that's sort of fundamental to why we're here doing this particular type of education. The other thing that I might just say is that it's not always 100% of the time the radiologist's report that you're actually going to hang the result of the imaging on. Sometimes it's the clinical information. It's actually what happened after the image is reported that you find out what the actual result was. And when I say actual result, I don't mean that doesn't align with the radiologist report. It may well align with the radiologist report, but sometimes it doesn't. Sometimes it's actually the clinical information. And, as I said in that introduction, bunch of other information is actually available to the doctor, not just the radiology, like clinical tests, blood tests, physical examination, all those sorts of things are thrown into the mix. And sometimes the result comes out of there, not the radiologist's report. And so sometimes that's a little bit of a dilemma for you that you'll have to negotiate. And I guess I'm sure you'll do the best you can with that.
Yeah. Okay, so I'm just going to share my screen again. I think is it this one now? It's this one, I think. With the clinical portfolio. So there's 2 reports that you will have to submit. So it's your clinical cases and then also the self-auditing record. And then there's the learning outcome. So you need to select cases applicable to this unit only. So just upper limb, shoulder, and the cervical spine as well. And then just under the resources tab, so there's a number of resources. There's an introduction PowerPoint about the clinical portfolio. So have a look at that. We could maybe, I don't think it's too long. It's just a couple. I'll just probably have to share again. Okay, so just because this is now PDF. I'm just going to scroll past all of these. So the resources, use the Moodle site, and then remember the information is under this week. So if you're unsure where to find information when it gets nearer to submission, look at the timetable again, and you will see where the information was posted under which week. And then there is, of course, the Moodle book. And then, as I've mentioned, the clinical portfolio has a weighting of 30% with those two upload documents. So the one will be on clinical cases, and the next one will be your self-auditing PIE record. And then that is the deadline for the clinical portfolio for this unit. So with your clinical cases, each case, as I mentioned, is about 80 words. So overall, the clinical cases that you upload will have an overall word count of about 2,000 words. But for this, I say, don't fret about the word count that much. It's more important about what you present and put forward under each case. And then, so in your submission for your clinical case, so each of those cases include the clinical details, which could be the mechanism of injury, for example. You need to include at least one de-identified image, and then write up your own preliminary image evaluation. So your own comment about the case. And once you've written that up, compare that then to the radiologist's report, and then write a comment about whether you agreed totally with the radiologist's report or whether there's been any differences. Now, you can mention patient immediate management. You don't have to mention that if it takes up word count, but if you feel you want to mention what happened immediately with the patient, you can include the immediate patient management. Then the marking rubric. So here we have got the symptoms of the patient. Use the ABC search strategy, which we are going to introduce. Some of you might know that, but you don't have to write about each of those. So A stands for alignment, for example. B is for bone. C is for cartilage and joints, and there's a S for soft tissue. So you can, if the alignment has been affected, but there's no bony abnormality, you only need to include about the alignment under the ABC search strategy. And then I've already included the PIE and the de-identified images. I've given an example which we've discussed. And then for the self-auditing record, you will then compare your PIE report to that of the radiologist. If it matches completely, and if there's pathology, it will be a true positive. If you both agree this is a normal case, it's true negative. And then false positive, if you incorrectly identify pathology which is not there, or false negative if you not mention that it is a normal case. And then, as I said, you can assign fractions as well, but each case must be equal to 1. So if you assign fractions, half plus half will have to make up 1. So if you've got a true positive and then a false negative, the other half, then there's these calculations you need to do, and I've given you the formula to work out the sensitivity, the specificity, and the accuracy, and then just a brief reflection as I've mentioned before. Now, how you work out your calculations. So for example, for the cervical spine, you will identify, okay, I've identified 3 true positive cases, so you'll have a number 3 and so forth as you go along. So if you've got 25 cases in the end, all of this needs to add up to 25 as well. This is what they call a 2-by-2 table. So it's a decision-making table where you assign either true positive, false positive, false negative, or true negative. And those are how you calculate. So sensitivity is where you identify all or most of the abnormals. The intention is you should have very few false negatives. So you want to pick up the abnormals, and then specificities where you exclude pathology. So you want to identify cases as normal, because if you overcall on pathology, it means that there's a much higher risk associated with treating unnecessarily, especially if there isn't a radiologist immediately available. And you might find that the referring physician might be junior and might rely on you to maybe assist him or her to make a decision around a case. And in accuracy, that is your overall accuracy rate. And there is the how you can work that out as well. Okay,
Sorry to interrupt. Do all of those percentages need to be done for each case and displayed for each case, or only at the end?
Only at the end. You can only work it out once you have completed this whole table. That's where you will add up all the true positives. So you will have maybe, say, if it's 25, you might have, say, 15 true positive. You might have true negatives, say another 5 true negatives. You might have false positive 2 and maybe a 3 false negative. So those at the bottom must add to 25. So it's the overall figure that you are going to use to work out the ratios, the sensitivity, and the specificity. Does that make sense?
Yeah.
Okay. All right, so I'm going to stop share on that one. With the clinical portfolio, everything else is just, okay, I might just go through the marking rubric for you. So let's just open that one up. So the marking rubric for this is very simple. So in the end, with all your cases, we will look, did you include symptoms, the presenting symptoms, or a mechanism of injury? Have you included a de-identified image, which is 1 mark, so at least 1 image, and then your PIE that you've written up, and also your comparison with the radiologist's report, and then also your self-auditing PIE record, which is marked out of 10, and then a brief reflection on after you've done the course, how do you feel about your image interpretation capability? So that is why the clinical portfolio is only submitted at the end of the course, so that you have got an overall feel of how well you've done, or if there's areas maybe that you feel you need to improve on. So I think that is the main things from the clinical portfolio. I've given quite a few other links there, but this is the main thing about the clinical portfolio. Is there anyone that has any questions? Because this was not addressed last night, because it's not part of 4502. Melanie, are you okay with that clinical portfolio?
Yes, I've more started thinking, how am I going to access 25 in total? Oh yeah, well, there was this patient and this patient and this patient and this patient. So my head's going through possibles already, because of course we don't have a radiographer or x-ray machine on site. So I'll see how I go.
Yeah, so I think the main thing is to try and start collecting, write down cases maybe that you've seen, and try and see if you can access it. For all of the students here is to start making notes of interesting cases, but don't forget to have normals as well. Quite often the students are so focused on pathology And then when they come to the normal cases, then their specificity percentage is very low, because if you've got 2 or 3 cases and you get one wrong, then you drop to about, say, 66% or something. So ensure that you have got a fair spread of normal cases as well as abnormal cases. The abnormal cases will normally exceed the normal cases, but I think for this, at least have between, say, 8 to 10 normal cases, so that you can work out very good specificity rates for yourself. Okay, any other questions around this? So Mel, if you've got issues, as Tony said, please contact us if you struggle to access cases. And as Tony also said, if there's a historical bank, I know with one of the other postgrad courses that I had, they didn't want the students to have access to active cases, but they had a bank of resources that they could work from. So some of the hospitals might have something like that as well.
Yeah, that's probably a good point, actually, Imelda, is that I know some health services, and I think Hunter, New England, yeah, I have some fairly strict rules around saving images and using them, even for teaching purposes, which I've found in the past. So if you run into that little minefield, you might have to give us a yell, and we'll sort of talk through it and see how we can work our way around that one with the help of the appropriate people.
Okay. So is there anyone on here that has got any questions about everything that we've presented about the delivery of the unit, the assessments for the unit, and then the clinical portfolio as well?
It probably all seems sort of fairly complex and a bit daunting at this stage, but it will sort of, as you go along, it'll pan out and everything will sort of come together. I might just, if I could, just take a few minutes to address the question that Mel asked last night, which is, like, I know that all the people here are doing both 4502 and 5108, and some may actually be doing more units as well. I was just having a look at the timetable myself for those first 2 weeks of those units, and I think that it's possible to actually balance your workload for those. In 4502, there's a little bit this week that you've actually got to get stuck in and do, and possibly, I think, not so much this week in 5108, but 4502, there's a lot of that sort of basic radiography introduction type stuff and what have you that I think, okay, let's actually maybe prioritize that a little bit. When you come to 5108 this week, there's stuff on reviewing basic imaging tests, so basic diagnostic tests. There's a PowerPoint there on diagnostic test accuracy and a couple of readings that are associated with that as well. And that's probably stuff that you can maybe not have as a #1 priority at this point, but I think nevertheless have a listen to it or have a look at it. With the diagnostic test accuracy PowerPoint, it doesn't have a voiceover, it's just a scroll through. And but there is an example there of how to calculate sensitivity and specificity and accuracy on a genuine case, a genuine set of images. So you might want to actually have a look at that and sort of see how how those variables, how those parameters were actually calculated in that particular case. There's a whole lot of, well, not a whole lot, but probably about 4 or 5 other parameters that are used to actually measure diagnostic test accuracy, and that PowerPoint actually refers to those as well. For your clinical portfolio, you don't have to calculate positive and negative predictive value diagnostic odds ratio. You don't have to do a receiver operating curve for the cases, but there's information there about those things because they are to do with diagnostic test accuracy, and you might want to actually have that information. And then when you sort of come to week 2, I think again there's a bit in 4502. I'm just going to go to 4502 again and remind myself.
So 4502 has a big focus on psychophysics of vision. So there's the Moodle book that has got 3 videos and PowerPoints, and that is the stuff that will be examined in the first exam that you're going to write for 4502.
Yeah.
Yeah.
And look, that's I think that is stuff that you can probably do moderately quickly. The principles of radiographic imaging. So this is next week, not this week. And radiographic evaluation criteria, PowerPoints. I think you can work through those. And then in 5108 next week, you sort of have the introduction
ISAP
to
case,
the
yeah.
ISAP case, yeah, which is, I think, not quite so onerous as 4502. So yeah, by sort of having a look what you've got in the timetable, and then having a look what's available online as we make week 2 available. Week 1 stuff is already up there, obviously, and hopefully you've actually already started working your way through that. You're not just waiting for this information session. Some of you may be enrolled also in other units, and I think 5109, you might find similar sort of parallels 5108 in some ways in terms of workload.
Yeah, and it's just the body parts that's going to be different for 5109, where it's the lower limb, the pelvis, and then the lumbar and thoracic spine.
Yeah. 5114, the workload is a bit higher and more consistent, even at this stage. But if still, I think just, match up those timetables and sort of see where you need to put your priorities. Remember that, further down the track when you've actually got a little bit more space, be it Easter or during the, other periods when you actually might not have as much workload, then maybe you need to do some catch up. But I think, yeah, it's tricky, but I think it's possible to actually balance that. Yeah, is that okay?
Yeah, definitely. It's trying to balance your own work life, because some of you have enrolled full time in the course, but you're still working as well. So ensure that you have time to do the studies, so that you can be successful. One thing you don't want to do is to waste money. Because if you're not successful, you've not just wasted money, you've also wasted your time. So ensure that you try and stay as much as possible on task. But as Tony said, focus on the immediacy things that you need to do. If there's some of the stuff that you can delay to work through, because, for example, the statistics stuff that Tony has mentioned is useful for your clinical portfolio, actually, which you're going to submit much later at the end of the semester. So if you want to maybe go through it and put it aside, when I write up my clinical portfolio, then I can go back to that and really work through that. Yeah.
Yeah.
Okay, are there any other questions? Because I maybe want to just stop the recording so that we don't have everybody's faces on it. Any questions?